I would like to invite the panelists, so Dr. Hani Al-Hashimi, Dr. Shaji Kumar, Dr. Scott Howard, and Dr. Tariq Uwaida to join the podium, please. So, I prepared some questions that I would like our experts to try to help us in getting the answers. So, for each question, I put names, but however, it will be open for all the floor. So, the first question is to Dr. Scott Howard: how do you motivate, convince healthcare providers to participate in health outreach activities?
Well, thank you again for inviting me, and I want to question the group. What do you consider outreach activities?
Okay.
I think everything can be an outreach. Outreach is a tool to help patients to have an access where they don't have that access. That can be access to medical care, can be access to diagnostic care, can be access even to therapeutic care. So I think outreach it's a broad spectrum kind of facility.
Yeah, I would second that. And again, it can be defined in terms of geographical terms, in terms of getting it into the community. It can also be in the same. It may kind of looking at the spectrum of services, as you already mentioned, whether it be diagnostic, education, and also interventional strategies. I think it's a question. So yeah.
I might just add to this is actually responding to the community needs. So what is lacking that you're going to just to supplement. Sometimes we do an outreach activity that is no use, just thinking that we're helping them. And as a matter of fact, they're actually not needing the service at all. So at the very beginning, you just need to define what the community wants from you to do, and then do that for them, so at least it's actually complementary.
Okay. So back to you, Dr. Howard. So we have defined that there is a need for healthcare for an outreach activity in an X region, and you want to convince a group of staffs to join you. So
okay, group. I want to disagree with all my group first, because I think an outreach activity is kind of like a goal, and I think what we would rather have is a system. And so what you just spent half an hour is describing a system that provides care to everybody in a logical way, in a cost-effective way, in a fair way, and a system that would make outreach activities maybe unnecessary or even meaningless, because the system would include the entire referral network. It would include who teaches who, where. It would include who trains who, where the trainee can go afterwards, how the incentives are to help people want to do what the system needs them to do. And I think I got to tell you about this book by Scott Adams. You guys familiar with the Dilbert cartoon? It's 30-year running, the only cartoon I know that's 30 years every day for 30 years. So then the Dilbert guy got bored making the cartoon, and he started writing self-help books. And I love his self-help books even more than his cartoon. And the first one is called How to Fail at Everything and Still Win Big. And so in this book he says, goals are for losers. Systems are for winners. And he gave the example of weight loss. And with weight loss, you set a goal, I'm going to lose 5 kilos. And then every day you're working toward this 5 kilos and you're a loser. Every day you're a loser. Then one day you achieve 5 kilos. Today I'm a winner. And then what do? You set a next goal. So you're a loser every day, except maybe one day if you succeed, and then a loser every day again. And he said instead the contrast would be a system. And his system is every single day he goes at noon, dresses his gym clothes, drives to the gym, and walks in the building. And he said, my system does not actually include exercise. So if he's feeling ill or tired or stressed out, then he still has to follow his system, which is get dressed, go to the gym, and walk inside. And he said, but he finds 19 out of 20 times he'll go ahead and exercise while he's there, because his system works. He's got his shoes on, he's got his clothes, and so the system is built to make him succeed. So every day he follows his system, he's the winner. And he said, my system also happens to lead to good health and weight loss as an incidental finding. And another system that he mentioned specifically was was about food, for example. And he said, so self-control is also for losers. He said, so you put ice cream in the freezer, and every day you have to not eat it. And it's sitting there waiting for you. And he said, so my system is, I have carrots, I have vegetables, I have things in my refrigerator. So if I want something that I shouldn't have, I have to get in the car, drive to the store, buy it, come back, open and eat it. So it's very difficult to do the thing he doesn't want to do. It's very easy. Then he says, open the refrigerator, I see a pre-prepared box of carrots with some nice sauce. And he said, I like the carrots, I like the sauce, so I prepared my system so that it's appealing and sustainable, but also will make it hard to do the wrong thing. I think for us, we've got to, let's think of Saudi Hematology. So which pieces of the system work very well? The people work great. Look around. So people, great. Education, great. Geographical distribution, probably not so good. Referral network, maybe half and half. Mostly relationship-based and ad hoc, but maybe a few channels that are built. So I feel like if we just worked on those two things, which would be the system of referral and the system of communication, boy, that would be, I don't know, I would like your feedback.
Yeah, I totally agree. I think having a system is very welcomed, but you have a gap between the system until you develop the system and the current need. And I was fortunate in my career to get exposed to outreach program that initiated by King Faisal 20 years ago. And frankly, what we got from that program, what you can see here, most of what we see in progression in Saudi, it was an initiate of a program of outreach. That doesn't mean that this program was perfect. It has a lot of faults, and that's where we are waiting to get a system where we have a referral, everybody knows what to do. But till you get there, I think still there is a room for outreach program.
Yield the floor.
No, I think you make a good point, but I think it's also important to know what the goal is. So we have to have that assessment of what is missing. Then you decide what is the goal that you're going to attain, and then you build your system according to what your goal is. If you build a system in vacuum, you could either overreach or underreach and not necessarily get to the goal where you have to be. So I totally agree. I think a system is definitely needed, but you also need to have that goal that builds or fills up the gap that you perceive exists.
Can I make a comment here, Feras?
Yes, please.
Okay, just one comment. The outreach 22 years ago, I used to go to outreach program, get a ticket booked, go on Wednesday afternoon, stay there in the hotel or the hospital, next day give a lecture, spend half a day, see some patients, come back. After 2 years, I wrote a letter to the outreach program that this is useless. It wastes time for those people who are there to listen to me, and it's waste time for me, because at the end of the day, there was no benefit to them, because 95% of the patient population is benign hematological disorders. And if I'm going to go and tell them sexy things about acute leukemia and transplant, they're not interested in this, and this is useless. That is what has happened to this country, is that every hematologist who wants to come and do fellowship looks at malignant hematological disorders, transplant, while the 90% burden of chronic disease in this country is hemoglobinopathies, sickle cell, thalassemia, and all these things. Nobody's interested to do this. Why? Because the reimbursement for that for a physician is poor. He does not get recognized. Somebody who's a transplanter gets recognized, whether there are only a few. So what you are doing is feeding into a system where there is less number of institutions who can accommodate them, while large number of institutions are not being based on developing specialties that will cater to the 95% of the population. That's why there's a famous Chinese proverb: if you give a fish to a person, you'll feed him for a day, but if you teach also a person how to fish, you'll feed them for life. So I think there has to be a fundamental change of what is the requirement, what is the fundamental burden of the chronic disease. Very long time ago, I wrote an editorial on a book that was Burden of Chronic Disease. This country has to understand what is the burden of chronic disease for Saudi Arabia. Burden of chronic disease is not transplant or leukemia, but the burden of chronic disease is something else. That's where they need to concentrate, and I don't know how outreach would help them unless, or malignancies where they have only hydroxyurea, and I go and tell them, why don't you use imatinib, go to a second generation, or use some 3+7 high-dose azathioprine, they look at me and they don't have, all they have is hydroxyurea. So I think there has to be fundamental change to accept that the burden of chronic disease is something different than what we are trying
Thank
to
you.
do.
Thank you, Dr. Naim. We'll have a point specifically to discuss how to have successful outreach program and how to measure the success. So just I'll move forward. So who's responsible for the outreach? And who shall perform it? Is it a responsibility of health, hospitals, societies, governments, international organizations like WHO? So this is the first part. And then who shall be involved? Do you need a general practitioner like general hematologist, or you need a bone marrow transplant? So I'll start with Dr. Hashimi.
Okay, so I'll actually continue where everybody ended. So I agree with the system, that we need a system for sure, but we need to define exactly what's needed. So at least when you build the system, you build it in a way that actually eventually will achieve the goals. I have a number of stories, but maybe this story is actually very nice to tell. 6 years ago, we actually, where we practice in the Eastern Province, it's our oncology center. 40% of the patient comes from another region called Al-Ahsa. It's about an hour and a half to 2 hour drive from our center. And the common thing that we kept hearing from the patients, it's actually a long distance, we're tired from coming, but we have to come. There is no cancer care in our region. So this is something that we needed to do. So that alerted everybody who worked in our cancer center that this is something that we might benefit from putting an outreach program there that will help certain patient population eventually. So we started the clinic that sees only survivors, and at the end of this year, we'll open a cancer center there. So if you ask me 6 years ago, were you expecting a cancer center to be built in Al-Ahsa? I'll tell you, of course not. I was not expecting a cancer center to be built there. And by the way, the cancer center that was built there was actually raised, and the fund was actually from the community there. It was not actually generated by Ministry of Finance or Ministry of Health. It was actually the independent health, wealth, and actually contribution of the community. So we started with a very simple program, very clear definition. We needed the patient to have access to certain things, and we kept pushing the envelope as much as actually the patient needs came on the table. So we started with oral chemotherapy, then we pushed it a little bit, so we did more training, we pushed it a little bit. So we were very responsive in doing the outreach activity. So without a system, without a clear definition, it's very difficult to know who is going to do what. I believe that outreach is actually genuine intention from everybody who actually practice medicine. So if you ask anybody, and that was actually proposed at the organization level and also at society level, number of society wanted to contribute to the outreach activity. Without a system, I cannot actually align everybody's intentions and everybody's will into that goals that we want to do. So as a short answer, a clear definition of what's need to be done tells you who's going to come on board to help with. If the need is actually a survivorship clinic, then you definitely don't need a bone marrow transplanter. You probably need a general hematologist that can actually do the job, general oncologist that can do the job. And that will continue to evolve as much as the community appetite and what they can actually ask for. What we saw actually from such experience, patient and the community don't ask for too much. They ask always for the minimum. They never ask us at the very beginning to give them chemotherapy in Al-Hassan. They ask us just to see us there. And the minute they started to see that there are things happening there, they started saying, how about? We reach after the how about goal. Then how about another milestone that they can? And then eventually they came themselves and they said, how about we actually raise some fund to build a cancer center? And boom, it's actually in a year time it's going to be open and running. So definition is important. System is very important to bring people to that.
Any additional, Dr. Kumar? Any additional comment?
No, I completely agree. I think to me, outreach, it's getting the healthcare closer to the person who needs it, whether it be a patient who needs a treatment or a healthcare provider who needs education. So it's a question of getting it to it's a proximity question. And I think, who can do it? I think anybody who has a resource. I mean, hospitals, societies, I don't know. It doesn't really matter. It's a question of who has a resource. In terms of who actually does it, and I think, the point about the chronic diseases, the benign hematological disorders, is very important. So I think the outreach here might be more maybe empowering the general practitioners to do those things. We don't even need a hematologist to manage many of those things, and making sure things are kept under check, and when things get to a point where they cannot manage it, that's where you may want the specialist to step in. So I think there's a lot of opportunities for non-specialized caregivers to actually implement that outreach. And I think that's where the prevention really makes, I think it's more important than trying to cure. So.
Okay. Dr. Tariq?
Just maybe I can add, again, who should receive and who should give. That's something needs to be defined in the outreach. Talking again about Saudi Arabia, which is a quite big country, and the practitioners not all at the same level, and especially if you move to urban areas, less cities areas, where you can find even practitioners at a consultant level, not at a level of a consultant, but they've been accepted to be working in the rural area. So these people, they need guidance. So the care provider, not only the patients, sometimes the care provider, maybe you do the outreach for some time just to put them on the track, give them more experience, hands-on experience, attending the clinic, attending the activities, not only to give a lecture. That will help them to move to another level and provide better care.
Again, just to highlight, I think one of the important aspects we didn't talk about the outreach is the trust factor. And I think the primary care providers will always have the highest level of trust for the patients. And if you can, as much as you can do things through them, I think there's more effectiveness for the implementation part.
Okay.
Thoughts from this area?
Okay, so we'll move to the next. So the question is, will be the location and where. So I'll divide it as a geographic. I mean, should you go to the closest areas to you where you're practicing, which is a county? Should you limit it to your country, your region? Should you go at the international level? And the second question is, how will you select this is an area that I'm going to work with? Do you have like a checklist of a minimum requirement in the center, receiving center? So, Dr. Howard?
Yeah, I think this is very good. And so it looks like we've already come up with 5 categories of activity that are under the rubric outreach. So this is really interesting, and I think you described a system which is listening to people. So that's just a system you do every day that will guide everything. So in my own case, I do a lot of the international version, but almost never going for a personal visit, almost always online. And this has really changed everything. So for example, every Wednesday morning, 7:30 Memphis time, 2:30 Morocco time, we discuss leukemia cases and lymphoma cases. For the past 15 years, probably 4 out of 5 Wednesdays. So imagine those hundreds and hundreds of meetings. And you would be shocked how there's a case comes up, AML and tuberculosis, AML when the blood bank is broken, AML when there's no pheresis, AML when the white count is 200,000 and there's no bed. So they actually developed outpatient hydroxyurea, white count less than 500,000 with AML. If there's no bed, there's no bed. So they just started. And then it turns out many of the patients got 4 days of hydroxyurea. So the novel finding was if they had a hydroxyurea good response, like the prednisone good response, they actually had a 50% survival instead of 20% for the others. So what I'm trying to describe, I think, is a system of listening, but also two-way communication. And maybe this two-way communication could support the primary care providers day by day by day. And I'm thinking of a friend in Brazil, and he got his cure rate up to 65%, and it should have been 80%. And he said, I don't think I can do any more by improving the hospital because they're coming late with these huge tumors or with high white count, going to ICU, dying. He said, I think the 15% that's left, I got to go to the community. So he developed this community training program and a community book in Portuguese and everything, and then went personally to 200 community health worker trainings. His state is like 1,000 kilometers east to west and about 300 north-south. So went personally, and I was thinking why this thing worked. And I think the reason it worked is it was personal. So he brought the proximity, which you described, but also on the guidebook, it had a cell phone number. And the cell phone number was to the hematologist oncologist. 24/7, they would just have that one cell phone passing along, and people would call this number all the time. And in 2 minutes, often they could get advice, send right now, or go to the pediatrician. These were not doctors, these are community health workers, bachelor's degree at the most of education, but they could call that phone and then take a good decision. So never more would a leukemia patient sit for a week without being referred on in. So I wonder if the cell phone and the who you call is 80% of the battle, and the last 20% is who's on each end of that phone. In the WHO, I feel like, so as you guys know, the WHO launched a childhood cancer initiative 18 months ago, but it turns out the WHO role there is to develop a technical package of why it's cost effective to treat children, which are 6 index cancers, which are highly curable, but all of these things, the only way to get them out is this communication network. So maybe our 3 systems are a communication network that's pre-established that includes the primary care and secondary and tertiary. Second, the commitment of individuals within that network. And third, a listening attitude.
Thank you. I think I will continue on the same line. I think I can talk about the involvement of the World Organization in the improvement in the outreach, but I will start with the current with country, local, regional selection of the center. I have an experience with one center which was initiated 15 years ago. And based on the demand of the center, they defined what they need. They needed diagnosis, improvement for detection and management of acute leukemia. That was Qasim region, which is close to Riyadh. It's easy access. So they contacted us and they identified the demand. And it was quite clear, we need to be a cancer center that can or be able to make the diagnosis, and we have the treatment. We went through that journey with them for 10 years. Now it's been considered one of the good centers in the country that provide the care for northern part of the country. And that because we listened to them. They initiated the process from them and they identified the needs. The same center, they identified later a need for starting benign hematology. So we went through them with the same through the hemophilia and establishment of hemophilia cancer center. So again, the center identified, then they asked the help, and then we could provide the help. So I would agree the checklist can be there. You go and see what they need. But if there is no clear objectives, demand from those who need it, you will be like going like what Naeem said, going once, twice, but without a goal. You need to have a goal. You need to achieve. And from international point of view, I think sometimes the international bodies can help you. And I have an example of the World Federation of Hemophilia, which came to us in 2002 in the country, where we were in initial phases of initiating the hemophilia care in the country. And with the outreach we started, that's an outreach from outside coming to Saudi to help us to establish a high standard care of hemophilia and offer like 15 years. Now we've been considered as one of the centers that completely independent, and our WFH is out just supervising the journey.
Yeah, I completely agree. I mean, I think the world is without barriers except when coronavirus shows up. But I think, with the social media, the way we can communicate now, it doesn't really matter. You can dream big and reach out anywhere in the world to get what needs to be done. So.
So it's as important as the team that's responsible on the outreach activity is the other team on the other side that received the activity in their area. We have an example over the past also 3 years, 3 years and a bit, and we published this in BMT, outreach activity for autologous stem cell transplant program, establishing the program. We have approached multiple sites in Saudi Arabia, and as much as it was actually challenging and difficult, the team on the other side made it possible. So we were able to establish 5 with the right team, and none, unfortunately, with the wrong team. This was actually pushed again outside the border of Saudi Arabia. So we're doing the same activity, the outreach activity, in Al Ain, in United Arab Emirates. So we actually crossed the border to do this activity outreach with a neighboring country. So it depends on the team on the other side as well. So if the team is not, there is no champion for this, nobody's interested in addressing this as an importance, it will take forever, and more than likely it will never be achieving the goals.
Okay, so moving forward, so I'll switch now to the challenges. So how would you handle the mismatch of capabilities and capacities at the receiving centers when it comes to the workforce or the facilities itself? So, Dr. Hani.
The situational analysis you did.
For which one? Okay, so in every center we did an outreach activity especially for the stem cell transplant program, there was actually a team that did a full SWOT analysis and evaluated every single component of the program and whether it's ready to go as is or it needs some capacity building and outreach activity, more than likely teaching related than resources related, because every place has the resources required. And once that is actually clear to both sides, it was very clear what to do next. So the plan was simple. And with regard to the human resource requirement, again, so for example, in Al-Hassa, this was actually the initial step in the outreach activity. At the very first visits, we used to go as a team of 6 people. Physician, nurse, admin, pharmacist, and a lab person. And also our nurse manager and a driver for sure. So it's a big team that used to go for the initial couple of visits. Today, if you ask me who goes, 1 person only. The one who's going to do the activity. Because most of the knowledge required to establish the outreach program has already been transferred. So this is a knowledge that's in the area. So with time, eventually the ultimate goal of any outreach activity is actually to provide care where care is not provided, and then people will take care of it for the rest of their life. So that's where things. So it takes time. That's what I'm trying to say. The right team, probably a lot of effort in the very beginning, but it pays off afterward.
Again, just don't want to repeat what has been told already. I think the main thing is just identifying who needs it, what do they need, and what do we need to be able to give it to, provide those resources. I think if you can answer those 3 questions, I think that will lay the foundation for a successful outreach program.
Okay. So going back is, what outcomes shall you measure? I mean, what outcomes and KPIs you need? Actually, I mean, I'm sure every one of the experts here has been involved in a lot of outreach activities. I mean, is it his subjective assessment, or it's? I mean, how to evaluate? I mean, Dr. Howard, he mentioned his example of Morocco. So, I mean, if you go retrospective, or if you ask someone else to review it, do you think it will be successful, unsuccessful?
Yeah, I would almost not do a program unless there was a commitment to an information system. And maybe that's part of my own personal system, which is if there's no interest to measure progress, then probably there's some other place that needs an equal amount of help. So the two-way listening. But I remember this one foundation in India, and it was based in Dallas. And no matter what they asked for, so the site might say, I need flow cytometry and I need a nursing training program. they would always get a data manager, a database, and a social worker, and a nutritionist, no matter what else they asked for. And he said, you can have your flow cytometer, but you get these other 4 things always, because I promise you, you need them. Whether you realize or not, you need these things, and nurse training, if they hadn't asked for that. So I kind of like that idea. You want bone marrow transplant? Fine, but you also have a nutritionist, social worker, information system, and a data manager. So he wasn't asking for anything that he wasn't funding also. But I feel like this two-way communication, part of the substrate of the communication is the patient's outcomes. So we're case-by-case discussion in Morocco, but then this developed over time to national protocols. So now it wasn't just cases, but also protocols and the outcomes of the protocols, death and induction. The Hodgkin protocol really caught my eye because we analyzed 5 protocols from 1980 till 2005 at the time. And the survival was 30% in every single protocol. And so they changed from protocol 1 to 2 to 3 to 4. And I said, well, what was the rationale from 1 to 2, 2 to 3, 3 to 4? And they said, well, whenever the French change, we change, because we use the French protocol. And so 5 consecutive French protocols, every time the French got 80% for 30 years, and Morocco got 30%. And so then looking at the spreadsheet, though, there was a treatment start date and a treatment end date. So 6 ABVD typically took 18 months to deliver. And so it's no surprise that the patient would relapse. In between every course, they would relapse and then come back, relapse and come back. So it wasn't really frontline therapy. It was really abandonment of treatment and then salvage therapy that was just more ABVD. Why do I say this too long of an answer? Because without the information system, we would never have known what happened to those Hodgkin patients. They would be at 30% today. Instead, they didn't change the chemo. They hired a social worker. And that social worker's only job was who came to clinic and who do I have to call to bring them to clinic and find out the barrier. And so that one thing alone, the event-free survival went up 30% with one social worker per center, 3 centers. So I think, the social workers in Morocco make about $400 US a month. So $1,200 a month, they're curing all these patients with old ABVD, which always was working in France and here and everywhere else. So it just hit me, the lack of information was actually killing people and wasting money and then wasting salvage therapy. Really, really bad. So I feel like information systems should be obligatory no matter what else you bring them. Everything else would include that too.
Yeah, to answer the question of the KPIs, I think an initial visit, as Hani had done with the stem cell, an initial visit to identify all the resources, available resources and needed resources. And then based on what you have, then you can put your targets, you can put your KPI. We would like to have a flow cytometry available with the trained person who we can achieve it in 1 to 2 years. So you can put a plan over time and be realistic, because you can't, especially if you would like to introduce a new service, you can't dream of it today and do it next month. It takes time, education, acquiring, not 1 month. So that's part of the goals. The second goal of the human resource, I think the goals is changeable here. Now, human resource is a difficult part. You can acquire flow cytometry or acquire whatever, but humans are a factor that is especially in areas where we have here a high turnover of personnel, where you can train this person and next year or maybe next few months will not be available. We had a bad experience when we started hemophilia, trying to initiate a laboratory diagnosis of hemophilia in each of the 5 centers in the country. We had done 2 workshops with the World Federation, and after 1 year when we came to analyze, we found those all whom we trained changed the career. So it's a challenge, but I think keep looking at your KPIs and achievements on periodical will be one of the success for the program.
Okay, last point is similar actually. Is what are the advices to have a successful program? It was addressed, but if any of the experts want to add last comment.
And just it's actually will go with the same lines, but. We live in an era where digital and data is actually very important to everybody, and it has to answer certain questions. It has to answer a question to the patients. And again, it has to answer a question to the providers and to the administration, because if I'm going to do an activity that costs money, I have to show them that this activity is actually cost effective as well. And it's actually causing cost reduction in my side, and maybe adding value on the other side as well. So KPI is very important to be developed to answer specific questions. Collecting data for the matter of collection is actually a waste of a human being time, and rather do something else rather than collecting the information. But specific KPIs that we felt it's very important and very simple, very basic, was actually number of visits, number of patients, patient-related outcome satisfaction, so was actually something that to be collected. And also a thing that the administration wanted to know, how much I'm saving doing this outreach activity. And we were able to show that it is cost effective. So when I actually pushed 40% of my patients to one side, I reduced this budget from my own hospital. Yes, I shifted it to somewhere else, but at least my admin were happy to provide me for what's needed to do this activity. And the other side felt that is actually an added value to them, and they were happy to put in the upfront payment for this services. So that's again, it completes the whole picture. So an activity without KPI that answer questions specifically to improve the program might be, goes missing without the right ones.
Okay. So I think by this we will conclude. So I would like to thank all the experts. So we will have a 25 minutes break. So we will be back at 3:30. It will be at Najd meeting room, which is in the hotel. Tomorrow morning we will be meet again at this meeting room. So thank you all.